So today it is my pleasure to introduce from Iowa City, the University of Iowa, co-presenters. Reintroducing Dr. Melanie Wellington, who is professor in the Department of Pediatrics. She provided us with another grand rounds earlier this year that was excellent. Also joining her is Natoshia Askelson, and she is an assistant professor in the Department of Community and Behavioral Health, and they have kindly accepted our invitation today to provide us with some information on how we can increase the vaccination rates in Iowa. And so please join me in welcoming Drs. Wellington and Askelson.
Thank you very much. It is fun to talk about this topic, and I hope if we keep talking about it, we're going to get even farther down this road, but here's where we are now. So we have some funding to acknowledge. Research on even how to improve vaccination rates doesn't happen without funding, so we're very happy to acknowledge the grants that have come in to help with this effort. I keep trying to do this with my keyboard. There we go. Okay, so our learning objectives today, we're going to talk a little bit about vaccine technology, which is not a term you may be used to using, but I think you'll see there are different strategies that we use to make these different vaccines, and I like to kind of think about how that impacts the vaccine success. And that will take us to one of our newest strategies, which is used by the Hpv vaccines, which are virus-like particles. More on that in a minute. And then we'll talk about what you can do to actually improve vaccination rates, because that's really, you are the person actually, you'll see, who has the most impact on vaccination rates in your practice. I know it sometimes doesn't feel that way, but that is true. So if you just want to read the take-home message and then start working on something else, that's your decision. We're all adult learners. But the take-home message is that vaccines work. We are having a problem. We can't make them work if they're not being given it to people. So that is where the problem is right now, not on the vaccine success. But we do actually know how to increase the rates of giving vaccines. So not only do they work, but we also have strategies for making them happen. Since I'm a card-carrying pediatric infectious disease specialist, I have to start with this slide. That's actually not true, but the point here is that us, the specialists, the scientists in us, the data people in us, think about vaccine success like this. And this is lots of small print. You don't have to read it. I'm a lumper, not a splitter. So basically, vaccines prevent up to 1 million infections per year, and those are pretty serious infections, and up to 10,000 deaths per year. But this isn't what people who are anti-vaccine would respond to, right? This is what the scientist in me responds to. But I think what we really need to be doing when we're looking at vaccine success is to tell these stories of success and really show people what success looks like. Because there's no fighting Jenny McCarthy with a table like the one I just showed you. Right? I mean, there's no competition there. But if I say to you that my mom was 14 years old in the middle of one of the worst polio outbreaks ever, and she didn't get polio because of a vaccine, or my dad didn't get a bad disease because of a vaccine, or I'm a vaccine success, I'm one of the last people who was actually vaccinated for smallpox, a disease that has now been eradicated. And not only that, but it keeps going. But my daughter turned 12, actually, believe it or not, on the day we started immunizing 12-year-olds for COVID. So this is what vaccine success looks like. All these smiling, happy people who are healthy and not someplace where they don't want to be, like a hospital. So, but what do we want from vaccine when we want to promote, when we want to achieve success? We have to get the immune system on our side. And I'll have a couple slides with a little bit of immunology in them, just enough to sort of keep us going with this sort of idea of what the vaccine is doing. Don't worry, I promise not to start talking in numbers and codes. But really, we all know this, but as a reminder, if you're looking at a level of an antibody, say, to look at a vaccine response, the primary immune response, either the first vaccine or an infection, generates a response. But very importantly, there's this lag time here. It takes the body a while to go, what was that? Right? It takes that time, and when the disease is happening from the infection, that time may not be something we have to spare. So the secondary immune response starts right away because we've already had that exposure from the vaccine. But not only that, but that secondary immune response is stronger. So if this is a second booster vaccine, or if it's disease after someone's been immunized, you can see we get a much stronger, more avid response. And this is what we really want from our vaccines. And this is also because, again, images versus tables versus people and emotions. This is also vaccine success. So this was actually a picture that was taken in 1901 by a local physician. These two boys were both exposed to smallpox on the same exposure moment, and one of them had been vaccinated before that exposure and one had not. And I think it's pretty easy when you look at an image like this to say, this is what vaccines are good for, right? And it can really kind of bring home how important they are. So the first vaccine technology I want to talk about is the live virus vaccine versus the inactivated vaccine. And I think the best way to do that is to talk about polio, because it's really a tale of two vaccines. In the 1950s, the U.S. was in the midst of the worst polio outbreak ever, and every year it was getting worse. And every year people were living in fear of this. They were telling their kids they couldn't go outdoors because of this. It was a big deal. And these are the overall U.S. numbers in 1952, but I have a hard time with that sort of stuff. So I use the back of the envelope calculation and some census data and that sort of thing. But imagine if every year in the city of Ames, 8 kids get polio, 3 of them develop paralysis from polio, and every other year one of them dies. I mean, that's scary, right? I mean, that is really scary. And it's not like there was no sense of, oh, polio is a pandemic and we're going to get through this, right? This was every year, and it had been that way for millennia. And so that was generating a lot of concern, and it also led to development of 2 vaccines. The first was the inactivated polio vaccine, and the biological science breakthrough that led to this was they figured out how to grow lots and lots of poliovirus in the lab, and then they formalin inactivated it so it couldn't actually grow in the person. And they did a field trial that involved 2 million children all in one summer. And in 1955, at 10 a.m., they had a press conference to say, look, this vaccine is 90% effective at preventing polio. That afternoon, the FDA authorized its use. That's how scared people were and how worried people were. Now, we've lived through the pandemic now, and we kind of remember last December when things went to the FDA and they got its EUA and everything happened pretty fast, but it wasn't that fast. And not only that, but of course, we're still having uptake problems. But with polio, people were so frightened and so scared, and they had all seen the disease, and they didn't have the sort of current culture that we have of question and doubt and anti-vax. And so they were able to roll that vaccine out really quickly and pretty much stop the polio outbreaks. One of the pros and cons, right, is that inactivated virus vaccine doesn't replicate in the body. That's a pro because it's safe. It's a con because you need a lot more vaccine in order to get that immune response triggered. You have to put in everything that the immune response is going to see. Not only that, but there are occasionally problems with the inactivation. So those are some cons. You compare that to live virus vaccine, which was developed by Sabin, and he really touted the fact that kids liked his vaccine much better because they put it on a sugar cube and they got to eat the sugar cube rather than a shot. And that was actually his big point. But he had a bigger point, which was scientific, and that's that it's all about the intestinal tract. So poliovirus is transmitted by fecal-oral route. So the first infection is in the lining of the intestinal tract. And so he felt that if we could get live virus into the intestinal tract that would stimulate local immunity, they could actually abort polio better than the killed vaccine. And he actually tested that on himself, so he believed in it clearly. It's easier to give, but most importantly, it gives a strong immune response at the site of infection. And that's fantastic. There are a few cons, though. It's a live virus, and it can mutate. So 1 in every 2.4 million times we give live polio, which we call oral poliovirus vaccine, it has mutation, reactivates the virus, and that causes something called vaccine-associated paralytic polio, which is bad. So if we don't need the live virus vaccine these days, we don't use it because of that. The other problem, though, is that because it's a live virus, it's also shed fecal orally, so shed in the feces. And then in areas with low sanitation and low vaccine rate, that virus can actually then infect many more people. And you can actually get an outbreak of a vaccine-derived virus in areas where the vaccine rates are low. It's kind of ironic because the response that you need to do to fix that is go in and vaccinate everybody. Yes, it will keep that circulating virus happening, but once everybody's immune, then that circulating virus will go away because it needs the people to replicate. So that's fantastic, and we now have only 2 countries in the world where there is wild-type poliovirus outbreaks. And so this is a massive vaccine success, especially because the first time I gave a talk at Mary Greeley, there were 3 countries. And I've only lived in Iowa for 4 years, so really it wasn't that long ago. So this is what vaccine success absolutely looks like. We have almost gotten to the state of polio eradication. And if we can keep that going without getting hung up by pandemics or wars or whatnot, pretty soon we'll have actually 2 diseases that have been eradicated. So what is this live virus immunity? This is as complicated of an immune slide as it gets, so hang in with me. So you probably remember most of this, but just to kind of bring it to the front, because we're talking about some more. There's a vaccine. It has an antigen, right? Goes into your arm or your mouth or wherever. The antigen-presenting cells in the body grab those antigens and take them over to T cells. And I labeled the T cells T. Kind of simple that way. So the T cell sees that and it stimulates all of the right different pieces of the immune response to make a response. And that includes stimulating B cells to make antibody, stimulating T and B cells to develop memory, but they can also activate innate defenses at the site of infection if you give the vaccine at the site of infection. They can actually activate local responses at the site of infection even if you give it intramuscularly in a little more complicated way. But also, T cells themselves can be killer cells, and that's really important for antiviral responses. So you get all of these responses from the immune system, but if you give a live vaccine, you're going to get more of these killer T cells, and you're going to get more of this sort of local stimulation of the innate immune system. And that is why there's some pros and cons to both of them. But that technology of being able to give a live attenuated strain changes the way we were able to deal with polio and vaccines. So the next step in technology, of course, is most of our vaccines are actually inactivated or protein subunit vaccines. And so I gave a few examples down here. And there's still antigen, there's still antigen-presenting cells, T cells are still stimulated, and the T cells stimulate antibody production and memory. But you'll see you don't get most of that other response here. And so some more challenges are how to get this response without having to deal with live virus vaccines. And so if you just deal with live virus vaccines and the subunit vaccines, you basically get to the point of eliminating or close to eliminating all of these diseases, but it doesn't touch Haemophilus influenza or Hib. And in fact, it also doesn't touch Hib's friends, pneumococcus and meningococcus. And that's because those are bacteria that have this polysaccharide capsule. This is an electron micrograph of a bacteria, and these polysaccharides here are surrounding the whole bacteria, and they're actually a way that the immune system can, the bacteria evade the immune system. And that response to polysaccharides, it turns out, is really an issue when it comes to preventing these diseases because there's an age discrepancy here. So if you look at Hib, Haemophilus influenza B vaccine, there's 2 sets of ages that get into trouble with Hib disease, or that did, because we've had great vaccine success. And that's the youngsters. It's 2 underneath the age of 2, they cannot respond to that polysaccharide rate. And over the age of Ys, you may pick that number that goes with, they also have lost the ability to respond to those polysaccharides. So the new technology that got around this was to conjugate vaccines. So what was happening here, and this is what we figured out using immunology and basic science, and we never would have gotten here had we not had that basic science data. So the basic scientists are just as useful for developing vaccines. But when an under 2-year-old sees these polysaccharide antigens, it's called a T cell independent response. And the B cell actually sees the antigen and starts making antibodies without the T cell helping it. Now, it can do that, and it can make really wimpy antibodies. It doesn't make very many, and they're not quite the right type. And so even though you could give the polysaccharide as a vaccine, under 2 years old, it's not going to make an immune response that's going to protect the kid. And that's annoying because under 2 years old is where the kids have the most disease. Probably quite related. So if you give somebody over 2 months old that same thing, you get the T cells involved, and then they make those memory cells. They make lots of great, good, strong antibodies. So how do we get around this problem? Comes up to conjugate vaccine. So the young immune system doesn't respond right to polysaccharides when they're by themselves. But it turns out if you take some of that polysaccharide and stick it onto an immunogenic protein and stick it on and stick it on and stick it on and stick it on, so it's repeated, it gets like Velcro, right? The immune response is all over things that repeat like that. And all of a sudden, even in the 2-month-old, right, to whom we give Hpv vaccine, you've got this fantastic T-cell mediated antibody response. You get strong antibodies, you get a lot of memory, and you can even get some of that innate immune activation. So this is why I like to say technology has really prompted our ability to increase protection from our vaccines. And you can see, you don't have to read these words, don't worry, but this is a graph of the incidence of Hpv in the world per 100,000 population. And up here is where we were trying to immunize kids with polysaccharides, and it wasn't really working. Here is where we gave our first conjugate vaccine, and then it was started to use widespread for kids who were 2 months old or older. And you can see we've just about, gotten rid of Hpv disease, which is pretty darn cool. Not only that, but that conjugate technology is now being used for pneumococcus and for meningococcus, and that actually has another really great side effect. So same thing, it's a conjugate vaccine. We can give it to 2-month-olds, and the pneumococcus is a little different because we had to have multiple different strains because multiple different strains of pneumococcus cause disease. But the red line here is disease from the strains that were in the 7-valent vaccine. And once we started giving that vaccine, you see those drop dramatically. Furthermore, then some new strains cause disease. They're the blue line that comes up here. And then we added strains to our vaccine, and they dropped too. So this looks like vaccine success. This looks like the slide I just showed you about Hpv. But something else really cool happened. This is the incidence of disease in adults. Now, we weren't immunizing adults, right? These are not people who are immunized. These are just people in the world. And the day we started immunizing kids for pneumococcus, their disease dropped too. This is actually called the grandparent effect, which is a kind of cool title as far as I'm concerned. And that's what made me put that picture in as vaccine success. Because what's happening is the pneumococcus was living in the noses of the 2, 4, 6-year-olds. And they were hanging out quite close with their grandparents and giving their grandparents pneumococcus. And so by eliminating it from the kids, we actually also eliminated disease in adults. And eventually we got so smart that we said, hey, maybe we should be giving the vaccine to adults too. And now we are. So that's a way technology, conjugation of polysaccharide into protein, has really impacted disease. So the last big new technology I'm going to talk about today, I know that we have mRNA vaccines, which seem new too, but we wanted to focus on stuff where we had data in terms of how to get people to take up vaccines, and we don't really have that for the COVID vaccines yet. But the last big new technology is virus-like particles. So, and that's used for the human papillomavirus vaccine. And what happens is when you have lots of virus around, those antigen-presenting cells are just like, they can't handle it, right? But if you just give them those protein subunits, they're just not stimulatory enough. The immune system doesn't make much of a response. It's like, okay, whatever. But what's really cool, again, found by basic science, is if you take all these pieces of the viral capsid, remember the capsid is the shell of the virus, it's just protein, and you put them at exactly the right conditions in a test tube, they assemble themselves into the shell. Now, they have no viral DNA, so they can't make a virus, but they can make that shell. And that shell then can't suppress the immune system, can't scare the immune system, can't do anything else, but the immune system can really respond to it. And this is pretty cool because this is our first vaccine for cancer. And I really think that we're going to talk some more in a few minutes about why we call it a disease for cancer and how that impacts uptake. But we've never had a vaccine for something like cancer before. And I think we really need to be out there telling people about it. And with that, I'm going to stop presenting. Oh, I don't want to end the presentation for everyone. I can't bear, Natoshia, you need to take control.
Taking control.
There we go. Okay.
I think I have taken control.
Excellent. You took control. I'm handing this off to the folks who, to Natoshia, who's very good at knowing how we can get people to use these vaccines that we have.
Thanks, Melanie. I do want to take a brief moment and just celebrate the fact that we got kids approved for emergency use for, yes, everyone can do their happy dance. This is a really big deal. Every county now should physically have vaccine as of last night in their county. And I'm very excited, looking forward to my nephew getting vaccinated very shortly, so maybe we can spend Christmas together. And I can tell you, we collect data for the Advisory Council for Immunization Practices at the CDC, the ACIP. And I can tell you the national data that we've collected for them really does show that they will be a bit of a push for parents who want the vaccine right away. But it is going to be a long haul to get 5 to 11-year-olds vaccinated. And so as I'm talking about some of the techniques we can use for other childhood vaccines, I think we need to be thinking about how these apply to COVID as well. And we'll certainly be testing them in Iowa. But just keep that in mind that we have a pretty big challenge coming at us. And it'll be a steep curve for us to go on. So thanks so much for having us here. We're going to spend a little time talking about the HPV vaccine. It's a really good example of adolescent childhood vaccines and kind of the evidence we have about how to increase uptake, because so many of our other vaccines, especially in Iowa, have really high uptake. Iowans in generally have been fairly compliant when it comes to vaccinations, especially for their kids, and we have pretty good mandates. We also know that Iowa is a testing ground for new legislation that is anti-vaccination. And so, we don't know how many of those bills we've been seeing over and over in our committee are going to come out and will be voted on by our legislature, but I'd urge you to kind of keep an eye on that, because we have been hearing a lot about a lot of new attempts to get rid of mandates, all kinds of things that we might be concerned about when it comes to childhood vaccines. So we're going to spend some time thinking about the HPV vaccine. So first, want to take a look at what HPV-related cancers look like in our state. So on the right-hand side, you'll see a list of all the HPV-associated cancers. And in the left-hand side is a map that comes to us from the Iowa Cancer Registry, where everyone who has cancer is registered and their data is kept. And you can see a darker county indicates a higher incident. The map shows HPV-associated cancer incidences that have been adjusted for age from 2014 to 2018. And so while Story County doesn't look too bad, it's got a lighter color, you certainly have surrounding counties that have darker colors. So HPV-related cancer is out there. This graph kind of allows us a little deeper dive into what's going on over time related to HPV-associated cancers in Iowa specifically. So that purple line is really the line of success of Pap testing, right? So it's cervical cancer among women, and we can see how that's declined really nicely over time. The other lines give us a little bit more pause. So that light blue line is male oral pharyngeal cancer, or what we call OPC, and that's been on a steady increase over time, especially in rural areas, but nationally as well. So something we're increasingly concerned about. And then the green dashed line is other male-associated HPV cancers that are not OPC, and the red dashed line is female-associated cancers that are not cervical cancer. So there's some concerning rates there as things are kind of going up in those categories. But the good news is we have a really highly effective vaccine that when we can get enough folks vaccinated, we're going to see those lines start to curve down as well. So on to our very highly effective vaccine. We know from NHANES data collected through 2003 to 2018 that we've seen declines in HPV infections among teenage girls and young women. In countries that have really high HPV vaccination rates or have mandatory HPV vaccination, they've seen great declines in HPV-associated cancer as well. So hopefully we get to that point at some time too. So I'll give you a little bit more about the vaccine. You all have a lot of things to pay attention to, and sometimes things change and you don't realize it. And the last 2 years, 18 months have been kind of crazy. But to make sure that everyone's kind of on the same page about where we sit with recommendations. So CDC does have some newer guidance on adults 26 to 45 around shared decision making for those adults who it might be appropriate to get the HPV vaccination. And then we've gone to 2 doses for younger kids. And I've actually seen the data on 1 dose. And maybe if we can get over this pandemic, we might have a chance for FDA to look at something like a 1-dose HPV vaccine, which would be really awesome. And the other thing I want you to think about on this slide is that the 9 to 10-year-olds, they are certainly within the range that can be vaccinated. But before, we've thought about it as a time where maybe you could vaccinate if you thought you might not going to see the kid again. It might be a good time to get it. Now we're really saying consider vaccinating at this age group. In fact, the American Cancer Society is strongly recommending that kids' vaccination for HPV starts at 9 to 10 for 2 reasons. One, they have some preliminary data that shows parents don't think about sex in 9 to 10-year-olds, and you can really concentrate on the cancer part of this vaccine. And 2, there appears to be something magical about recommending only 2 vaccines at a visit. Parents are much more likely to agree to give their kid 2 vaccines than more than 2 vaccines. And so if you're in that 11 and 12-year-old range when you're vaccinating HPV, you're likely to be also vaccinating for Tdap and meninge, which means you're up at 3 vaccines, and parents might balk at 3. And HPV would probably be the one that they would say no to because it's not required for school. And so if you get that HPV vaccine earlier in that 9 to 10 group, we've got a lot better uptake. So I think there'll be a lot more talk about this as kind of the pandemic hopefully winds down and we can focus more in this area. The other thing I want to be sure everyone knows about is that previous to this past summer, we were not able to say that Gardasil 9 prevented oropharyngeal cancer. And because it's such a big deal, we were very concerned about that. That has now changed. FDA has now, it's now as an indication. And so we can say with lots of certainty that the HPV vaccine prevents oral cancer. So that's really important. So I want to give you a little snapshot of where we think things are with vaccinations in Iowa related to HPV, with the caveat that the pandemic has certainly made things a little harder for us to be able to assess this. But first, if you look at U.S. data, so if you go to the right-hand side of this graph, you'll see we've got Tdap, meninge, and then up-to-date HPV. And you can see there's quite a gap between where we are with Tdap and meninge and where we are with HPV up to date. And so that gap has concerned us all along and continues to concern us. But we're not there where we could be with the other adolescent vaccines. Then we want to look at Iowa kind of specific data. And there's 2 things I kind of want to highlight here. One, we have this really amazing immunization registry system. And for kind of all the heartaches we've had over the past few years with the pandemic, the one thing that has been really great in Iowa is how we have this IRIS system. Many states do not. We're probably one of 10 states that has a really robust immunization registry system. So people can actually access this on the Iowa Department of Public Health's dashboard. And so the public can go in and they can look at a number of vaccines over a number of different time frames, different age groups across the state. And it really gives folks a nice idea of where we're stacking up in terms of other immunizations. And so I urge you to kind of take a look at that to understand kind of statewide and in your region how you stand. The other thing I want to say is that providers have access to these data, and they really are very rich. And although you're always going to find cases where kids are going to have missing immunizations or you can't find the kid, right now about 96% of kids in Iowa are actually in this registry. So we have really good coverage. So it's a place where you really can go find your kids, find out what their immunization status is, really be much more confident that where your patients stand. And we work all over the state in different clinics, and I can tell you providers have a tendency to overestimate how well they're doing when it comes to immunizations. And so pulling data like the immunization registry data can really give you a good check in terms of, okay, where do we stand? The other thing I want to show you is just we actually have access to the HPV, Tdap, and meningitis data through an agreement with the Iowa Department of Public Health. And although we haven't been able to get this data since June of 2020, this is what we have through June of 2020. And just want to point out, we've broken down immunization for HPV, just initiation, having 1 or 2 doses for 11 and 12-year-olds and 13 to 15-year-olds. And so you can see those 11 and 12-year-olds, we're really in that 20% range. Urban females are almost at 30%. And rural males are just at 21%. So there's a lot of work to do in that age range in which kids are supposed to be receiving the vaccine. We do not have enough kids receiving that vaccine. If you go to 13 to 15, the rates certainly double, which is great. But they are nowhere near the 80%, which is the target for Healthy People 2020, which was a year ago, and Healthy People 2030. So keep that in mind moving forward, that we aren't doing a good enough job when it comes to HPV. We like to create maps. We think they're really interesting visuals. And so here's a map that shows you HPV initiation, so 1 or 2 dose, as of June 2020 for 11 to 12-year-olds. And the darker your county, the higher your immunization rate. So the highest county we have is about 34%. You can see Story County is in there at kind of a lilac color, but not quite the dark purple. So aiming for the dark purple. So there's some work to be done there. And because our counties are big and arbitrary and political lines and don't really represent communities very well, we actually break the data down to look at the zip code level. And so what you see here is a map based on zip code. So if you can kind of pick out your zip code, which most people don't know what the shape of their zip code is, but you get the general area. The darker outlined areas are considered more of our metro or urban areas. And so the darker the green, the better your rate. And we've got some zip codes who are in the top quartile, so in the 25 to 100% of kids vaccinated. And then the red areas are red for danger or red for stop. Those are places where we have really low vaccination rates, 0 to 25. And then you can see we have some yellow in there that's very concerning, kind of that southeast section of Iowa, that far eastern corner, and then some north central and northwest. For those of you who are statistically thinking about this and you're like, well, the kids on the border communities are probably getting their vaccine someplace else. Yes, they are. And this map actually accounts for that. So we worked really closely with our Department of Public Health to account for that. And so it's those folks who are further away from some healthcare settings too that have less likely to have vaccinations we've seen. So I do want to highlight some recent challenges to the HPV vaccine, as well as some of these we can think about related to other vaccinations, including COVID-19. So first I want to talk to you about some work that one of my PhD students who just finished this past summer, Grace Ryan, did. She was very interested in missed opportunities. And missed opportunities are defined as times when eligible adolescents interact with the healthcare system at a visit at which a vaccine could possibly be given, and it doesn't happen. And so she took medical claims data from an insurance company that insures folks in Iowa and looked at kids 11 to 13 and looked at when they were getting the vaccine and how many missed opportunities they had and what kind of missed opportunities those were. So the kids actually they're initiating at a not bad age. They're initiating at 12, which is not awful. It's not in our 9 to 10 range, but it's not a bad initiation age. But then when we start to look at the missed opportunities, if you look at the missed opportunities for non-initiators, so those are kids who have never gotten an HPV vaccine, they have interacted with the healthcare system at least 6, almost 7 times. So there are 6 to 7 opportunities when they could have gotten the vaccine, they were eligible, And the visit that they were at was a visit in which you could give a vaccine, so the kids weren't horribly sick or anything like that. So a lot of opportunities where kids did not get an HPV vaccine. And then if you go to the bottom line, you look at missed opportunities for people who've initiated. So these are kids who've at least gotten a vaccine, but before they got that one vaccine, they had between 3.6 and 4 missed opportunities. So it took 3.6 to 4 times for them to get their first vaccine. So those were places where they interacted with the healthcare system, but did not get a vaccine. So we're obviously interested in these visits, right? We want to know, are they visits where healthcare providers made a recommendation? Maybe they made a recommendation and they didn't do a very good job, and so parents didn't take up on it. Maybe parents were like, no way. Or maybe vaccines were not talked about at all. But we think it's really key that folks understand how many times they're interacting with most kids, and realize that those are all opportunities at which vaccines can be talked about. And especially we need to be thinking about this as we move forward, thinking about the COVID-19 vaccine and all the catch-up vaccines that kids are going to need, thinking about using every visit possible as a vaccine visit is going to be really important for us to get everybody caught up. This is a kind of a scary graph brought to us by CDC. So CDC took the 10 states that had the strongest immunization registry systems, and Iowa is one of them. We're highlighted there in yellow, so you can kind of see it, and said, how bad did things get at the beginning of the pandemic related to vaccines? And this one is specifically around HPV doses, but there are other graphs that show other vaccines. And to walk you through this a little bit, that center line you see, that is the average number of doses that were given out in 2018 and 2019. So that's kind of like a baseline. And so you see our line dips way below that at the beginning of the pandemic and kind of slowly starts to come up to maybe what the average is, goes a little bit over the average, and then goes back under. We don't know how things are right now, but we know this itself is a lot of catch up to do. CDC has estimated just in the year 2020, we have 20 million missed HPV doses nationwide. So that's just HPV, that's not Tdap, meningitis, MMWR, any of those other things that kids need to be getting. We got a lot of missed doses just in 2020. So the good news is we do have some ideas about how to change this. We do have a lot of evidence-based interventions and things we can pull from. So specifically, there are 2 places I want to call your attention to where if you're interested in working on this topic, either in your community or in your practices, the NCI has the Evidence-Based Cancer Control Program, which really houses any interventions related to cancer that have been proven to be effective. And you go in there and you can get all the information and everything you need to get an intervention up and running. Some of them are at the community level, some are at the clinic level. Great kind of one-stop shopping there. And then we have the community guide, which is really the corollary to the preventive task force that decides what kind of screenings and things insurance companies might cover and what's best practices. So they decide what's best practices related to interventions. And so they have a whole series on vaccinations, and they've gone through all the evidence and looked at what evidence is there to support different kinds of interventions. And so you can go there and find out, if we're going to do this, does this make sense? Is this been shown to be ineffective? Is this one makes things worse? So another great place to go start if this is something you're interested in. So there's a lot of things that you all can do without even having to go visit those websites. First, we think about things happening at the organizational or clinic level. And so these things have been shown to be effective, not only with the HPV vaccine, but with all vaccines. And we are certainly rolling them out in our COVID-19 vaccination work. These are the things we'll be focusing on for COVID vaccine as well with kids. So reminder recalls, whether it's text messages, telephone calls, postcards, letters, getting parents in front of them that they know that their kid is delinquent in a vaccine. And we've worked a lot with Iowa's Medicaid managed care organizations who've done this with postcards and done this with text messaging around HPV, just to try to get more parents aware that they need to be getting their kids in and that their kids are delinquent. Setting up that next appointment before the patient leaves, really key with any 2-dose vaccine. So thinking about HPV, thinking about COVID-19, having standing orders. That sets the playing field for everybody to know that this is what we expect everybody to get when they come in our door. And there doesn't need to be any kind of special conversation between providers or staff about what people should be receiving. This will also be something to be thinking about with COVID-19. Provider assessment and feedback. Like I said, we spend a lot of time going around to clinics all over the state, larger health systems, as well as small independent clinics, rural and urban. And providers universally overestimate how well they're doing when it comes to vaccines. So both when we pull iris data and when we pull data from electronic health records, when you actually get the data on the patients that are attributed to you and you see what those vaccine rates are, it's always eye-opening and also can be very motivating. So it's a great way to benchmark and think about, okay, what can we do moving forward? Provider reminders. I am old enough to have worked in a clinic where we used colored sticky notes. So, we don't have colored sticky notes anymore, but there's no reason why you couldn't use colored sticky notes if that works for you. Electronic health records are both wonderful and awful, and reminders in them can kind of get lost. So you need to set up a reminder system that works for you, and it may not be the electronic health record. And then the other thing is using your immunization registry data, being sure that you're scrubbing your schedule every week for patients, making sure you've got their vaccinations, making sure you know what they need. All of these things are kind of best practices that I think in general, everybody really knows or agrees with. But we actually go into clinics and we do statewide surveys with clinic managers and Vaccine for Children liaisons. And we ask, are these things in place for HPV? And I can tell you, by and large, they are not. So the last survey we did was 2018, and these things were just not being implemented for HPV. Sometimes they were implemented for younger childhood vaccines, but not for HPV. So I think this is something everyone probably needs to go back to, reconsider, think about it for other vaccines, including COVID. And then we're getting to the fun stuff. So the provider recommendation, the part where it really all lands in your lap. So we know that provider recommendations are incredibly powerful. In fact, when I started my career working on colorectal cancer screening, it was the thing that predicted most whether or not someone would get a colorectal cancer screening, is whether their provider told them they needed it. So it's really valuable, very powerful. You hold a really important key. So we think about provider recommendation in kind of 3 ways: a strong recommendation, an announcement approach, and a presumptive approach. And throughout the rest of the slides, you'll find websites that you can go to that will give you a lot of detail and let you kind of personalize this stuff on your own. So let's dig into it. First, we have somewhat seems like fairly simple advice. You need to find a script that you like. You need to find some text that rolls off your tongue. American Cancer Society has some, the National HPV Roundtable has some, and CDC has a ton. They have a ton of scripts. They also have a ton of videos where you can watch healthcare providers interact with patients, where you can watch healthcare providers talk about their interactions and what works and what doesn't work for them. Spend 20 minutes. Find some language that works for you. Memorize it. The presumptive approach. For some reason, it's been shown that when healthcare providers walk into the room, they assume that parents are going to be hesitant or not want vaccines. And when you actually do surveys and you look at what parents want and what providers perceive, you see a pretty big gap. Most parents aren't hesitant. Now, we know COVID may change this equation some moving forward, but pre-COVID, most parents were not hesitant. And so going into the interaction, assuming that parents are going to agree sets a very different tone than if you're assuming you're going to be facing some kind of challenge. Make a strong recommendation. We don't offer vaccines, we recommend them. Your child will be getting today. I recommend that your child gets today. Bundle that recommendation and think about the magic of 2 vaccines. So if 2 vaccines is really kind of the maximum that parents really want their kid to have in one visit, and Melanie and I have kind of hypothesized, maybe this is just because you got one arm and there's no more arms to shoot immunization in, or that, there's a lot of myths around your immune system being overloaded. 2 vaccines does seem to have some magic. So if you're going to take that as a way to approach things, think about which 2 vaccines make sense for you to approach in that visit. If you're going to go for 3 vaccines, make sure you get HPV in the center, so it doesn't seem like it's optional. And you need a formula. So a lot of people say, I'll say the age of the kid, then I'm going to say what I'm going to vaccinate them with, and I'll be sure that I sandwich the HPV vaccine between the other vaccines. So have some kind of formula. Don't give up. Evidence says many people will say yes after you ask again, sometimes even in the same visit, sometimes in another day. Remember, think about all those missed opportunities and times when you do have to have that conversation. So keep that door open, keep asking, keep recommending. If they start to question you, you really focus on safety and efficacy and the effectiveness of these vaccines. We have incredibly safe adolescent and childhood vaccines, and the effectiveness is amazing. Those need to be things that we hang our hat on. Those are things we should be proud of. And remember for the HPV vaccine that this vaccine prevents cancer. It's not about sex. You don't have to go there. Early campaign messages, for those of you who remember the first rollout of Gardasil, did go there, and that was a big mistake. The company never should have done that. You really need to focus on sex. So at this point in time, Melanie, should we go into role playing, or you want to take questions? What do you want to do next?
Yeah, so I was sitting here thinking about that, and I was thinking, given that the 5 to 11 day recommendation just came out, let's do what the group wants to do. We did put together some role playing that we could sort of show you how some of this works in those critical conversations. But if people would rather spend some time talking about the COVID vaccine or a different topic, then we want to be doing what's going to be most helpful for you guys. So if you feel strongly one way or another, put something in the chat real quick, or maybe if there's somebody in the room who can kind of give us the mood of the room, anything that's going to sort of steer us one way or another. Hearing nothing, unless I'm going to wait a minute longer, because I know sometimes it takes a while to get that chat activated or whatnot. Tim, are you in the room? Oh, Steve Hallberg's raising his hand. Okay. I saw the hand raised, but now I don't know. And then I got some.
Steve, can you unmute?
Yeah. Yes. Let's see. See if we can find him. Nope. Okay. I'm not seeing anything. Are you? Oh, there we go. As far as role-playing goes, I'm interested in how you'd respond to folks who do focus on sex. How do you resolve their concerns or communicate that this is focused on cancer? That is an excellent point. And let's see. I think that so we have one of the, looking at our scripts to see if one of them was sort of there, but we off the cuff, right? So I might say if Natoshia is a patient who's come in and I say, well, I'm so glad to see that Riley's doing so well today. The last thing on the list is vaccinations. Hint, hint, don't say it that way. There's a Tdap booster and meningococcus shots. Oh, and the human papillomavirus vaccine. What do you think about those? And then we're gonna, I think, improv here to pull this more towards the sex conversation. So
I'm okay with that Tdap and meninge because I think they need that for school. But that HPV one, that, my kid is not thinking about sex. He's still playing with like Legos and stuff.
Right, absolutely. And I know this is going to sound strange, but that is exactly the time when we need to immunize people. Because this vaccine, while the virus itself can be transmitted by sex, the vaccine itself is designed to prevent cancer. And by giving them to him now, he'll never have to think about it again. And he will be protected from this virus that causes cancer. So you can kind of acknowledge their concern always, right? Step number one. But I do think, especially when people are focusing on, it's like, well, he's not going to have sex, she's not going to have sex, so they're only going to have one partner. The other thing I sometimes do will say, you know what, the funny thing about human papillomavirus is that some huge portion of our country has this virus with no symptoms at all. So it could be that somebody has the virus, never knows they had it, and one sexual interaction transmits that and puts that person at risk of cancer for their life. And we don't want them to get cancer, and use the word cancer as much as you can, right? But again, of course, little Johnny is never going to have sex. Riley, Cameron, whatever, they're only ever going to have sex with the person that they marry. And that may be true, or it may not be true, who knows. But the other thing, right, the studies show us that the first time that teens have sex, it's usually not planned. So it's not something that we can wait until they're ready and then vaccinate them, because usually by the time they're ready, they've actually already done it. All of that stuff that you have in your toolbox for talking about sex with people, right? Just really say, I hear you, that the virus absolutely can be transmitted sexually, but that can be done in a single encounter without even knowing it's a problem. And the idea here is to get them prepared and protected from this virus to prevent cancer. That kind of stuff.
We've also heard from a kind of a small segment of parents in the survey research we've done that are concerned that the giving kids the HPV vaccine kind of gives them a license to be sexually active, or means they'll be less careful. And there's absolutely no evidence of that, either in the United States or internationally, or in a place like Australia where it's required for kids. If that was true, things like we'd find other things would be preventing kids, right? HPV hasn't prevented kids from not having sex, right? People haven't been like, I don't think I'm going to be sexually active today because I might get cancer in 20 years. So being sure that you're really focusing that on it's a cancer prevention, and there is no evidence that it kind of gives kids a free license to kind of go be sexually active.
Yeah. So another question about role-playing for patients who don't trust the government. This is the tough one, of course. The first thing to remember here is they trust you. There's lots and lots and lots of data out there that even though they may not trust the government, they may not trust CDC recommendations or whatever, they trust you, they have a relationship with you, and you are the person who has the most power to communicate about this sort of stuff. The other thing, in addition to saying that, is all of these little pieces of things that come up that you have a personal, like this is the one I always trip up on, right? I have a bunch of those in my list. That's where some of these sites with all these different scripts come up, because you can kind of scan through there and find one that plays to your weakness. We can sort of start partway through the CAM script Cam, I'm so glad to see you're healthy. Today, in order to help you be even healthier, you are due for a booster vaccine called Tdap and 2 new vaccines. A vaccine that prevents cancer caused by human papillomavirus and one that prevents meningitis. While you're here, we can also give you your flu vaccine so you don't have to come back, right? And so Cam's parent says,
my kid doesn't really like shots.
and then we have the thing where we talk to the kid, and then it comes out eventually that even if we could convince the kid, don't you love it when parents talk like that? Even if you could convince him, we're against vaccines, right? And so, and I would say, really, what is your concern about vaccines?
Oh, you're having me all over.
I messed up.
Let's say the COVID vaccine is new and it's really too new to know if it's safe. I've read stories on the internet about terrible things like infertility that can happen to kids.
Yeah. So, I hear about the internet. I can never tell which of those stories is really based in truth and which ones are just clickbait. I saw this awful story this morning about how McDonald's Sprite is so strong it killed Prince Philip. So again, really kind of putting into frame that the internet is not the place for accurate information. And then for the COVID vaccine in particular, people often talk about, well, there's never been an mRNA vaccine. How do we know that that's going to be safe in 20 years, right? And I can say this has actually been incredibly well studied. The reason we were able to make that vaccine work so fast is we've been studying mRNA vaccines since 1997. And there have been hundreds of trials on these vaccines. And the reason we haven't got one into our regular schedule yet is just we haven't gotten one that's fitting just right. And we really wait until we've got something super safe and super effective before we put it into the schedule. And that's why this seems new, is because you haven't seen it or heard about it before. And then, really focusing on it seems new, but we have a ton of information about it. And I understand your concern about that, right? I was a little bit hesitant when my daughter turned 12. What should I do? And you know what? I talked to her about it, and she wanted it. She wanted her life back, right?
I think the other thing to keep in mind is, I think the distrust of government, distrust of CDC. That's going to be a continued theme, whether it's COVID or something else. It's clear that that's here to stay. And so not having that trust in institutions, and then not having maybe shared values around science or community protection that maybe we used to have with our patients and with our community members, means that it isn't hopeless. It just means it's going to take more than one conversation. So this needs to be an ongoing dialogue. This is not going to be a dialogue where you're going to feel like every day you've won and you've gotten a bunch of patients vaccinated who didn't want to be vaccinated. It's going to be slowly moving that really big rock up a really steep hill, because it's going to be hard to kind of rebuild that trust. And it's just not going to happen in one conversation.
Right. And then really sort of saying, I hear you. I was worried about that too. I went back and went through the data myself, right? Or I went through the data and I made this summary of it. Let me give it to you, right? So this is my review, not the CDC's review, because again, they trust you. And then you're always okay saying, how about if we make another appointment to talk about this more? Because, of course, it always comes up, right? Like, right when you've got like 15 kids who are waiting for their ear infections, and this visit has already gone on half as long as it should have, right? But always okay, say, let me give you some information. Let me give you something to read. Let me send you to a site, whatever that might be, right? Give something, and then say, let's make an appointment to talk about it. And then make the appointment before they leave.
Yeah, and unfortunately, because of COVID, I think we're just going to see this with a lot of vaccines that you didn't have problems with before. And so I think it's now is the best time to arm yourself with your scripts and what you're going to say and what websites you want people to go to, because it is probably going to become more of the norm. So prepare yourselves now.
Yeah. Don't hesitate to ask people what their specific concerns are. Because a lot of people are just sort of like, well, I don't know. I just they hear so much about vaccines being bad. Or, a good friend of mine who's actually an EMT called me one day because her kid had just gotten born. And she's like, I know that it can't be as bad as they say there is. But where there's smoke, there's fire. So can you tell me what the data says about where the actual fire is? What do we actually need to avoid? Right? So really get at specific concerns too, right? Take it down to specific and get them information.
Looks like we got one more minute, or nope, we're out of time as I speak.
No. If any of you have more concerns, COVID vaccine, HPV, whatever, please feel free to get in touch with us. Well, just get in touch with me. I shouldn't volunteer you, but we're here, right? And it's not easy. The great thing I learned about when we put this talk together is how many different websites are out there to support you figuring out how to say these things. Those are very helpful.
And it's clear there's going to be a lot more information talking to parents about COVID-19, so keep your eyes out for that. So there'll be more resources coming.
Yeah, and then we have a resources slide, I think, don't we? That we can flip through. This obviously is being recorded, and you have handouts with the slides on them, so you have all this sort of stuff. But if there's any problems or whatever getting that, just let us know. Thank you all so much for sticking there through this with us, and thank you for having us. I know this is a really difficult topic, and I appreciate so much that all of you are working to make it better. Well, have a great day, everyone, and we will see you as soon as we can.